Our next speaker, who will talk on sedation in COVID patients, is a critical care clinical pharmacy specialist and a postgraduate Year 1 pharmacy residency coordinator at St. Joseph Hospital in Tampa, Florida, USA. A board-certified critical care pharmacist by the Board of Pharmacy Specialties. She had her residency training in critical care pharmacy at the Jackson Memorial Hospital in Miami, Florida. She also took her residency training in pharmacy at Tampa General Hospital in Florida. She earned her Doctor of Pharmacy degree at Albany College of Pharmacy and Health Sciences in Albany, New York, and graduated as a magna cum laude. So today, to discuss the sedation in COVID patients, let us all welcome Dr. Amelia Casalenuovo.
Good afternoon. My name is Amelia Casalenuovo. I am a critical care pharmacist in Tampa, Florida, and today I will be going over pain and sedation management strategies for COVID-19 patients. Before we begin, I did want to disclose that I have received a speaker's fee from Delex Pharma International Incorporated for the development of content and presentation of this learning activity. No funds were provided to endorse any medications or products from the compensating entity. I will also be discussing off-label indications for medications within this presentation, and I have no other conflicts of interest to disclose at this time. After today's presentation, you should be able to describe sedative and analgesic agents available to use in the management of mechanically ventilated COVID-19 patients. You should also be able to identify unique patient-specific characteristics of COVID-19 patients, while also being able to construct an analgesic sedation management plan in those who are mechanically ventilated. Also, you should be able to evaluate medication shortages and pharmacy operations considerations related to analgesic sedative agents and recommend appropriate alternative agents taking into account patient-specific factors. Before we dive into pharmaceutical management, I wanted to provide an overview about COVID-19. Specifically, coronavirus disease 2019, which I will refer to as COVID-19 throughout the rest of the presentation, is a novel disease caused by the severe acute respiratory syndrome coronavirus 2. It requires high-quality supportive care to effectively manage the disease. Globally, patient outcomes and mortality vary, with most patients presenting with acute respiratory failure. Mechanical ventilation necessity varies based on patient-specific characteristics and practice settings, but that range is usually anywhere from 10 to 88%. Retrospective studies have indicated that COVID-19-induced acute respiratory failure tends to require prolonged mechanical ventilation. Due to the extent of mechanical ventilation support required, COVID-19 patients tend to have increased analgesic and sedation requirements, thus giving pharmacists an opportunity to help optimize extensive medication regimens. Generally speaking, sedation management should be tailored to the individual and continually reevaluated over time, usually aiming for light sedation. There are situations in which deep sedation will be required, and we'll talk about those in a few minutes. Patient-specific factors that will influence our decisions as it regards to sedation are pain and delirium, duration of mechanical ventilation, post-ICU complications, as well as length of stay and patient disease state-specific factors. As I mentioned, usually light sedation is our goal. Patients that are undergoing ventilator weaning should be maintained on light sedation, as well as those who are anticipated to have a short ventilator duration, and those who have minimal vent settings. Now, patients that require deep sedation are going to be patients that will be receiving neuromuscular blockers, patients with higher mechanical ventilation requirements, as well as patients with refractory hypoxemia. In patients who usually require deep sedation, they're oftentimes going to require 3 agents. So that would usually be an opioid infusion, propofol, and a benzodiazepine. So we'll talk about those agents in a little more detail later in this presentation. The same principles we just discussed apply to patients with COVID-19. Early studies and clinical experience with regard to sedation requirements have shown that these requirements tend to be higher in critically ill patients receiving mechanical ventilation with COVID-19. In fact, 50% of patients required 3 or more agents by day 2 of mechanical ventilation. When the studies looked at these patients closer, they found some interesting commonalities amongst them. The first one was that they tended to be younger. They also tended to have a higher BMI. They also tended to have higher serum ferritin and lactate dehydrogenase concentrations, as well as a lower PaO2 to FiO2 ratio. They were also more likely to be receiving neuromuscular blockers. Drug shortages have also necessitated the use of second and third line agents, and in some cases, having to minimize provider exposure has further complicated the process. Given these factors, pharmacists have a great opportunity to help the team effectively manage these patients. As Dr. Conley mentioned in the first presentation, the PADIS guideline recommendations to use an assessment-driven, protocol-based, stepwise approach for pain and sedation management in critically ill adult patients still applies. I wanted to go over the difference between analgesia-first sedation and analgesia-based sedation. Analgesia-first sedation considers using an analgesic before a sedative to reach a sedation goal, while analgesia-based sedation suggests using an analgesic instead of a sedative to reach a sedation goal. While it's ideal to be able to manage patients on analgesics, that won't always be the case where we can only use those agents. Some considerations in which patients might need a little bit more than an analgesic would be patients undergoing ethanol withdrawal, patients with high mechanical vent needs, patients receiving neuromuscular blockade, patients undergoing prone positioning, as well as patients with elevated intracranial pressure and patients in status epilepticus. The majority of the rest of the presentation will be focused on the agents that we can use and some dosing strategies and key characteristics about those agents that make them ideal for patients. To highlight some characteristics of our opioid agents, most patients start with fentanyl and are transitioned to another opioid if side effects or patient-specific factors preclude the use of fentanyl or they're unable to achieve their RASS goal on fentanyl. The table above is adapted from the 2013 PAD guidelines, but I'd like to draw your attention to the IV dosing section. Based on the guidelines, the recommended IV dosing for fentanyl and hydromorphone are 50 to 200 micrograms per hour and 0.5 to 3 milligrams per hour, respectively. Now, with COVID-19 patients, we have gone up to 300 to 400 micrograms per hour in fentanyl and 3 to 5 milligrams per hour in Dilaudid, respectively. To go over fentanyl in a little more detail, generally speaking, it is hepatically metabolized and is highly lipophilic. Therefore, it redistributes into muscle and fat easily and can result in significant accumulation in the obese population. It has a minimal effect on blood pressure compared to morphine and can be titrated quickly, which is why we most often use it. With respect to COVID-19, many patients with severe ARDS are obese, thus alternative agents may need to be considered if higher doses are reached. Fentanyl can also increase chest wall rigidity, thereby potentially worsening mechanical ventilatory compliance. When looking at hydromorphone, it is also hepatically metabolized and has a longer duration of action when we compare it to fentanyl. It can be beneficial for patients that have built up a tolerance to fentanyl and or morphine. Due to the longer duration of action, if hydromorphone is being given intermittently, it will usually require less frequent boluses and can be given when titrating patients off sedation. With respect to COVID-19 patients, hydromorphone is less lipophilic than fentanyl and therefore more attractive in morbidly obese patients because it wouldn't tend to accumulate as much. If bolus doses are used because it can be given less often, it can decrease nursing exposure due to less frequent dose adjustments. Also, hydromorphone has enteral options that are available that will be helpful to facilitate ventilator weaning. The last opioid I wanted to talk about in more detail is morphine. Generally speaking, morphine is also hepatically metabolized via glucuronidation, and it has a renally eliminated metabolite that can cause histamine release, which often contributes to the hypotensive effects that are seen when morphine is administered. From a COVID-19 perspective, the hemodynamic effects of morphine can be a concern, especially for patients that are receiving vasopressors. If patients are receiving ECMO due to morphine's more so hydrophilic nature compared to fentanyl, it is a good option for those patients. Caution is advised in patients with poor renal function due to the potential for metabolite accumulation, which can potentially cause neurotoxicity, hallucinations, tremor, seizures, and myoclonus. Usually, transdermal agents aren't things we consider at first for patients receiving continuous infusion sedation and analgesic regimens. However, in times of need or due to drug shortages, transdermal agents might need to be added to a sedation regimen to help concern alternative agents or to help wean patients off continuous IV agents. In general, transdermal agents could be considered for patients receiving continuous IV opioid infusions for more than 48 hours and are hemodynamically stable, not paralyzed, with expected use to be continued. With respect to fentanyl, patch absorption is variable and can be increased with heat exposure, which, in the setting of COVID-19, could occur in patients experiencing cytokine storm, thus leading to increased side effects. Another important characteristic of the fentanyl patch is that its onset is delayed by about 24 hours. With this extended time, it does take a little bit longer to see the effects of a dose change and therefore is definitely not an ideal option for opioid-naive patients. Looking at the lidocaine patch, it is another option that can be considered. You can use up to 3 lidocaine patches per day, and they're usually applied for 12 hours on and 12 hours off. From a pharmacy operations standpoint, it's important to have a mechanism or a trigger to the nurse to ensure that the patch gets removed for the full 12 hours. When used transdermally, lidocaine has minimal side effects. IV use is not usually recommended and was not recommended by the PADIS guidelines due to questionable benefit and the risk of cardiac or CNS toxicity, especially with elevated levels. However, in times of drug shortages, there may be specific patients in which its use might need to be considered. Ketamine is another agent that we can consider as an alternative to sedatives. It's a non-competitive NMDA receptor antagonist that blocks glutamate. At low doses, it has a dissociative effect that produces analgesia, usually up to about 0.5 milligrams per kilo per hour, and that effect diminishes as the dose increases. Ketamine dose ranges vary by institution, and the PADIS guidelines do not address a dose for sedation. However, most resources will suggest a max dose of 2.5 milligrams per kilo per hour. Higher doses have been used in difficult-to-sedate patients as well as in status epilepticus. The half-life of ketamine can be longer or shorter depending on the dose used. The main adverse effects are tachycardia, hypertension, and sialorrhea. However, BIS readings, hallucination, and psychosis, as well as elevated intracranial pressure, have been identified. When using ketamine, it really is an attractive option, especially for COVID-19 patients, and that its analgesic properties can help conserve utilization of IV opioid infusions, especially if there is a drug shortage. Furthermore, modest doses of ketamine are less likely to cause significant respiratory depression, which also makes it an attractive option for patients being weaned from the ventilator and or patients being weaned off sedation. However, some things to consider with ketamine is that it does come with a lot of volume, especially when doses are higher than 1.5 milligrams per kilo per hour. It can also cause increased secretions, which may complicate ventilator management. Ketamine can also deplete endogenous catecholamines and cause cardiac collapse by exhausting the compensatory response and thereby decreasing cardiac output. So these things are things that we want to be monitoring for as pharmacists if we're recommending these or if our patients are receiving ketamine. Dexmedetomidine is another alternative to sedative agents. It's a selective alpha-2 adrenoreceptor agonist with anesthetic and sedative properties that is structurally similar to clonidine. Doses used in COVID-19 are significantly higher than the 0.2 to 0.7 microgram per kilogram per hour recommendations by the guidelines. Doses up to 2.5 micrograms per kilo per hour have been documented. However, once the dose is greater than 1, tachyphylaxis does occur. Bolus doses are usually avoided, especially in patients that are hemodynamically unstable due to hypotensive concerns. Onset usually occurs within minutes, and the half-life can be up to 3 hours or longer with patients that have hepatic impairment. It is highly lipophilic and is highly protein-bound. As I mentioned, bradycardia and hypotension are the two most common adverse effects. However, loss of airway reflexes can occur and can lead to obstruction in non-intubated patients. When considering using dexmedetomidine for COVID-19 patients, there are a few things that we want to keep in mind. One of the main benefits of dexmedetomidine is its ability to reduce the amount of IV opioids needed via spinal analgesia due to alpha-2 receptors that are present in the dorsal region of the spinal cord. It has also been shown to have a reduced incidence of delirium, especially compared to benzodiazepines, which is helpful for agitated patients and is an ideal agent for patients that are ready to be weaned from the ventilator. Providing light sedation is a double-edged sword, as dexmedetomidine has no role when deep sedation is needed, such as patients receiving paralytics or patients undergoing proning. The main side effects of bradycardia and hypotension also make its use difficult in hemodynamically unstable patients. And if patients are on it for an extended period of time, it is important to remember that rebound tachycardia and hypertension can occur. Moving on to our sedative options, propofol is an NMDA receptor antagonist and GABA-A receptor agonist that has sedative, hypnotic, anxiolytic, amnestic, and anticonvulsant properties, but has no analgesic effects. Usually boluses are avoided due to concerns for hypotension. However, a loading dose is usually recommended at 5 micrograms per kilogram per minute over 5 minutes if it's going to be given. Infusions generally range from 5 to 50 micrograms per kilogram per minute, although significantly higher doses have been used in COVID patients, often up to 75 micrograms per kilogram per minute. The half-life of propofol is short when used short-term. However, long-term use can lead to a half-life of up to 2 to 3 days. Propofol is first line for light or deep sedation due to its rapid onset of action and elimination. It's highly lipophilic and has a large volume of distribution and is highly protein-bound. Hypotension and respiratory depression are the main concerns, along with hypertriglyceridemia, pancreatitis, green urine, and propofol-related infusion syndrome. When using propofol in COVID-19 patients, it is still a first-line agent due to its rapid onset and elimination, which remain advantageous in our COVID population as they do in our general mechanically ventilated ICU population. By using propofol, we could reduce the need or dose of benzodiazepine-based sedation as well as reduce those side effects. Propofol has also shown immunosuppressive effects in animal studies, which is promising. On the contrary, using higher doses of propofol in COVID-19 patients leads to more side effects such as hypotension and elevated triglycerides. Given the low incidence of pancreatitis reported in previous studies from elevated triglyceride levels and the potential for COVID-19 patients to have elevated triglyceride levels from COVID itself, it is reasonable to consider alternative sedation when triglycerides are greater than 800 to 1,000 as opposed to the traditional upper limit of 500 based on limited literature. However, care should be taken to monitor for signs and symptoms of propofol-related infusion syndrome. Moving along to our benzodiazepines used for continuous sedation, I did take this table from the PAD 2013 guidelines, but wanted to highlight a few key characteristics. To go back to benzodiazepine's mechanism of action, it does enhance the effects of GABA at the GABA-A receptor, resulting in sedative, hypnotic, anxiolytic, anticonvulsant, and muscle relaxant properties. Midazolam and lorazepam are the most commonly used agents for sedation, with doses for midazolam ranging from 2 to 10 milligrams per hour and doses for lorazepam ranging from 1 to 10 milligrams per hour. However, intermittent doses of diazepam are sometimes used during times of drug shortages. I will also point out that there have been higher doses of midazolam and lorazepam used in COVID-19 patients. All benzodiazepines can cause respiratory depression and may cause a slight drop in blood pressure that is far less than alternative agents. The main consideration is propylene glycol toxicity with lorazepam, which primarily occurs with higher doses, but has been seen in patients receiving as little as 1 milligram per kilo per day. The concern with midazolam and diazepam is that they have active metabolites. When using benzodiazepines in COVID-19 patients, there are some things we'll want to consider. Midazolam, lorazepam, and diazepam all have the potential to accumulate in hepatic failure, while diazepam and midazolam are more likely to accumulate in renal failure. Given the negative outcomes associated with benzodiazepines, such as increased length of stay, increased recovery time, increased duration of mechanical ventilation, increased delirium, attempts should be taken to reduce their utilization when possible. However, in situations where patients cannot receive propofol due to elevated triglycerides, or when patients have elevated creatine kinase or are hemodynamically unstable, benzodiazepines can be an effective option. When they are used, best practice considerations are to utilize the lowest effective dose and attempt to wean benzodiazepines first when starting the process of weaning sedation. I'd like to briefly discuss the use of neuromuscular blocking agents and their considerations in patients with COVID-19. Neuromuscular blocking agents and their associated monitoring will be discussed in more detail during the ARDS presentation. For COVID-19 patients with suboptimal oxygenation despite maximized ventilator settings and sedation, paralytic therapy can be considered. One distinction I would like to make is that proning is not the same as neuromuscular blockade. Proning refers to placing a patient on their stomach to increase oxygenation to the back or bottom of their lungs, and this can be accomplished without the use of paralytics. However, some patients may need intermittent bolus doses when transitioned from the prone to supine position. If continuous infusion neuromuscular blocking agents are used, they are monitored using bispectral index as RASS goals are not validated. As a pharmacist, one of the interventions we can make is bringing up the use of neuromuscular blocking agents on rounds and ensuring their continued use is reevaluated daily and stopped when clinically appropriate. Unfortunately, many of the agents we commonly use were on shortage early on during the pandemic. For some institutions, this necessitated the use of last-line agents for sedation and analgesia. With respect to fentanyl analogs, remifentanil, sufentanil, and alfentanil, remifentanil is similar to fentanyl but is metabolized much faster, therefore has a shorter duration of action. Because of this short duration, it is important to ensure pain control is optimized prior to continuous infusion discontinuation. Sufentanil and alfentanil are ultra-short acting and about 5 to 10 times as potent as fentanyl, but are not often utilized in the ICU. Moving on to pentobarbital, it is most frequently utilized for refractory status epilepticus or medically induced comas. However, in times of shortages, it can be considered for use as a sedative. Most of the data surrounding its use as a sedative is limited to pediatric patients. Lastly, the inhaled gases sevoflurane, desflurane, and isoflurane are most commonly used for general anesthesia during surgery. Data regarding their use for sedation is limited and mostly short-term, less than 24 hours in nature. If inhaled gases are being used, we must consider their risk for malignant hyperthermia and dose-dependent cerebral vasodilation, which can reduce blood pressure and cerebral perfusion pressure. I would just like to highlight that these agents are not usually agents that we will use, but in times of drug shortages, if we cannot acquire other sedatives, we may need to consider their use. I'm going to go over some oral agents that we can consider on the next few slides when we're ready to wean patients off of continuous IV agents or things that we can use as adjunctive therapy to continuous IV sedation regimens. As I mentioned, when it comes to oral analgesics, they really are a great option that we can add to reduce the amount of IV sedation needed as well as to conserve IV sedation supply during times of drug shortages, as well as to help facilitate extubation. The first agent I want to discuss is acetaminophen, which can be used and is usually dosed 3 to 4 times a day with a maximum dose of 4 grams or 2 grams if liver dysfunction is present. Gabapentin is another great option that also helps reduce anxiety and can help facilitate sedative weaning. It's also a great choice if alcohol or opioid withdrawal symptoms are present. It's usually dosed up to 3 times a day with a dose reduction to 1 to 2 times daily if needed for renal failure. The maximum dose is 3,200 milligrams per day. Similarly, pregabalin can also be used for the same reasons as gabapentin and does require renal adjustments. Both of these agents are also good choices for neuropathic pain, as is carbamazepine. Carbamazepine is usually started at a lower dose of 50 to 100 milligrams every 12 hours and titrated to effect. Compared to gabapentin and pregabalin, it does have the potential for more serious side effects such as hyponatremia, Stevens-Johnson syndrome, and toxic epidermal necrosis, but no dose adjustments are needed in renal failure. Lastly, I did want to mention ketorolac. Ketorolac is an NSAID that can be used but should be avoided in CHF patients or cirrhotics. There is increased bleeding in patients that have renal failure that are given ketorolac as well, so that's another situation that you would want to proceed with caution. If it's being given orally, it's usually dosed 10 milligrams every 4 to 6 hours as needed with a maximum dose of 40 milligrams. If it's given IV, it's usually dosed at a starting dose of 15 milligrams IV every 6 hours and then can be increased from there to a maximum daily dose of 120 milligrams. What's important to keep in mind is that ketorolac is limited to a 5-day duration therapy. Giving opioids enterally, either PO or through a feeding tube, is another great option to help wean patients off IV opioid infusions. Patients receiving larger doses of fentanyl, greater than 200 micrograms per hour, may need significantly higher oral doses of oxycodone to help wean them off continuous infusions. Generally speaking, most patients will need anywhere from 15 to 60 milligrams via their feeding tube or orally every 4 hours. Methadone is another agent that can be used but should be reserved for patients that have been on continuous opioid infusions for an extended period of time, at least 72 hours. It's important to remember that IV methadone is about 2 times stronger than oral methadone. Methadone also has more side effects such as QTc prolongation, especially if patients are receiving other drugs that have this side effect. It is a CYP3A4 substrate, so it does have that implication for drug interactions as well. One of the main considerations in weaning patients with opioids is that this will not be a fast process. Weaning infusions, especially in patients that have required them for weeks, will take time and should be guided by the side effect profile of available agents as well as patient-specific factors. To finish our discussion on oral sedatives, I wanted to go over first using oral benzodiazepines. To consider their use, consider the patient's total daily dose of equivalent midazolam that they are receiving, which 1 milligram of lorazepam is equivalent to 2 milligrams of midazolam and 10 milligrams of diazepam, then slowly wean IV midazolam as oral agents are added. Phenobarbital is another great option that patients can receive enterally, especially if they're undergoing alcohol withdrawal. Usually maintenance dose ranges are from 1 to 3 milligrams per kilo ideal body weight divided up every 12 to 8 hours. Clonidine is another attractive oral agent, especially for patients that were receiving dexmedetomidine. If we do use clonidine, it is important to wean it over 3 to 5 days to prevent rebound symptoms. Valproic acid is another agent that can help treat agitation as well as provide additional sedation. It's important to remember that it does have the side effects of thrombocytopenia, hepatotoxicity, and hyperammonia, and is contraindicated in pregnancy. Lastly, antipsychotics can be used, but based on current guidelines, minimizing their use is recommended. Both olanzapine and haloperidol can be given IM, and haloperidol can also be given IV. As Dr. Conley discussed in the presentation before me, I wanted to revisit the ABCDEF bundle and consider the effects of COVID-19 on the bundle. With regards to our ability to assess, manage, and treat pain, oftentimes this is decreased in COVID because there is a use of higher doses of continuous IV opioids, which can oftentimes decrease the ability to assess pain. With regards to spontaneous awakening trials and spontaneous breathing trials, the use of increased sedation, especially deep sedation, may make it so that these are unable to be performed. With regard to the choice of analgesia and sedation, drug shortages and patient-specific factors of COVID can impact this response. Delirium can be a fact and oftentimes is less assessed due to the amount of sedation required. In terms of early mobility and exercise, the use of increased neuromuscular blocking agents and sedations can prevent that from happening, as well as the potential for precautions on COVID patients. Lastly, family engagement and empowerment can be limited due to hospital visitor policies. As pharmacists, we play a huge role in ensuring optimal care for all patients and collaborating with providers. While COVID-19 is a unique disease state, it's important to consider the patient as a whole, including things like VTE prophylaxis, stress ulcer prophylaxis, blood glucose management, electrolyte management, antibiotic stewardship, nutrition support, bowel regimens, etc. An ideal way to do this is to develop a standardized daily checklist or rounding tool that you can use every day. As mentioned earlier in the presentation, many patients with COVID will need increased levels of sedation, which should continually be evaluated daily. Another thing that we can do as pharmacists is to optimize medication timing to help prevent the nurse from having to enter the room more times than necessary. From an operational standpoint, it's important to monitor drug shortages, especially to consider alternative agents, ensure inventory is accurate, as well as updating automatic dispensing cabinet inventory, especially on floors that might need to be converted to ICU floors. It's also important to develop and implement clinical protocols to ensure that optimal care is provided, as well as conserve drugs on shortage. New order sets will often need to be built and continually reevaluated, as well as infusion pumps to consider agents that might not often be utilized otherwise. In summary, designing an analgesic sedation plan for ventilated COVID-19 patients should take into account patient-specific factors, medication properties, and health system policies. Sedation management should be continually reevaluated for appropriateness with a focus on pain management and light sedation. When weaning patients off high continuous infusion sedation doses, consider the use of oral agents. Lastly, a plan to manage drug shortages and utilize alternative therapeutic options should be constructed.